Welcome to the Real Integrative Medicine Podcast. I'm Dr. Jordan Robertson, and I'm here to bring you the tools, insights, and strategies to take your health to the next level while using evidence-based integrative medicine. What's real? This is what we want to explore together. Research is ever-changing and not easy to interpret. We're bringing you the best that integrative medicine has to offer while sticking to the facts. Our mission is to elevate the practice of integrative medicine for clinicians and patients alike. Preventative solutions, nutrition, exercise, and sometimes supplements have a seat at the table in medicine, but only if we uncover real science-backed solutions. It's time to uncover what works and challenge what doesn't. Let's unlock your full health potential with an integrated approach. Ready to learn what's real? Let's dive in. All right, welcome to another episode of Real Integrative Medicine. We are going to talk about hormones, hormone therapy, and how women's health is so much more than just talking about hormones, even though I will say as practitioners, and I'm sure my guest will agree with me, that the pendulum has swung a little far in the other direction. I remember being a very pro-hormone therapy practitioner many years ago and feeling like I was beating my head against the wall, trying to educate people around why it was beneficial, trying to help them get the prescriptions that they needed access to. And now the pendulum has really swung so far the other way that like all of us, very hormone literate practitioners are like, whoa, that's not what we meant. We didn't mean give, slather hormones all over all people at all times. And yet sometimes that seems to be the way that the conversation has gone. So I've invited my good friend and fellow naturopathic doctor, Dr. Brittany Schamerhorn, to the show today for us to have this conversation about women's health and it extending so much beyond hormone therapy. Welcome, Brittany.
Hi, thanks for having me. Excited.
Can you introduce yourself to our audience? You practice in British Columbia. You practice in beautiful Kelowna, where I have family, and so we actually have been able to share cups of coffee over the last couple of years together, which I love. But I would love if you could introduce yourself for our audience and share why this is an area of passion for you.
Yeah, so I'm a naturopath in BC, and I think that's important to the conversation because it also means that I'm a prescribing physician. And then for most of my patients, I am the one prescribing the hormone therapy, if that's what we're doing. In addition to a naturopathic doctor, I am a mom of 2 young girls, mentoring, educating, and my biggest passion, I would say right now, is helping women feel more empowered as they're entering either perimenopause or just like navigating their own healthcare, but then also helping clinicians navigate this realm and this area and feeling more confident because it is super overwhelming and a lot of our education is very piecemeal. Like you take a cardio course, or you take this course, or you take that, and there's not a lot of putting it all together. And then what do I do with the patient who is asking to check their hormones? And it's really hard to connect all of that knowledge into there. And so I'm really passionate in helping clinicians feel more confident in that.
Yeah, what, as you were talking there, it kind of reminded me how, when standards of care are changing, they change pretty slow, right? It's rare that we have this revolutionary upheaval in the way that we treat something, and that's maybe not always to the patient's benefit that things slowly make their way into standards of care, but it's actually partly to the benefit of their clinician because it rarely requires such an overhaul of our education to be up to date, right? There might be a new drug or a new application of a drug or we learn something new about cognitive behavioral therapy. But menopause in the last 5 years has undergone a massive upheaval where, we're now demanding a different standard of care. And suddenly we have thousands and thousands of clinicians that are maybe not as well equipped as we hope they would be to be able to navigate this.
Or I think even because patients are starting to ask for it. And I think what is happening is we're looking at the symptom management of menopause symptoms and looking and taking that into whole person care, which it's not. And it's part of it, but it's not everything. And the community or the conversation online is missing that. And I think it's fair, right? Because hormones weren't having a voice. We were saying, don't do it. We were missing a big aspect of care. But when someone will come in just asking for that, and it's only part of the story. And as clinicians, it's tough to know, how do I take the patient from here to caring about this part of it, when this is a significant aspect, but it's really just one part. And it's that buy-in for the patient. But even because the clinicians are like, oh, I have to figure out how to do this now. Like, okay, like this is new. We got to do this. Our training isn't the best, so we have to do the extra on top. And then suddenly we forget too, all the other stuff that we already knew how to do.
I love that you said that, hormone therapy is, on its own is not really whole person care. Can you just take that one step further and tell us what you mean?
Yeah. So I will often use like when I'm talking with patients, I'll say we have to do symptom management, and then we're also doing like disease prevention, life optimization, etc. And sometimes it's the same thing, but often those are two different treatments. And we have to keep both in mind. And so if we look at hormone therapy and night sweats or hot flashes, those women are not getting great sleep. They're generally not eating well. They're not exercising, etc., because this is what's happening. So we might use hormone therapy to help with that. But now that doesn't mean they're necessarily doing the things to help improve their cardiovascular risk, because I still have to help them exercise, work out, like get their nutrition in and make sure there's that part of it. And then I think that hormone therapy, specifically in perimenopause and menopause, can be the gateway to really great lifestyle and whole person care, but it's just the start of it. And as clinicians, we're like leaving people at the door, because we're giving them the education, we're starting the prescription, we're doing this, and then we're like, okay, have fun. But we're not helping them actually learn how to use that tool so that it can best optimize their future life.
Do you know what I was dying for when I was a practicing clinician? I wanted someone to summarize the latest research, tie it up with a nice little bow, and deliver it to my inbox every single month. I'm Dr. Jordan Robertson. I'm the host of the Real Integrative Medicine podcast, and this episode is brought to you by my free integrative medicine magazine called The Stacks. We're all dying for unbiased, unindustry-funded information to help us be the best in practice. The Stacks delivers you quality articles every single month on the latest research on things you care about in practice, as well as opinion articles and business advice for integrative practitioners and naturopathic doctors. You can subscribe to the Stacks with the link in the show notes today and get access immediately to all of our back issues that show you exactly how to be an evidence-based practitioner. I hope you sign up and you'll enjoy it.
Yeah, I've always been curious, when we look at research on pharmaceuticals, there is always this discussion around compliance, right? And follow through and like lifetime use of what we'll maybe call in air quotes lifetime drugs, right? We know that when we give prescriptions, and patients kind of lose sight of what it's for, they're confused, they have a question, they actually come across maybe misinformation or conflicting information online, they have to take something for a long time. All of those things become these barriers to compliance, and we watch, chronic disease management suffers greatly with people just not taking their meds. And I'm so curious if we're going to see this trend in hormone replacement therapy in a couple of years, because this fanfare around the prescribing is not being followed up with fanfare around the long-term management of these patients. And I'm so curious if we're going to realize in 10 years that no one's taking their HRT, or they're not taking it as prescribed, or they're skipping doses all over the place.
They think that's it. Like, they're like, I got the prescription. That's it. Like, I'm good. Like, I'm taking care
and now
of
the slope of osteoporosis. Yes.
And then, so it's almost like it's almost like a Band-Aid effect, because we feel like it's covered, so I don't have to worry about anything else. Whereas sometimes when we're working to better ourselves in whatever way that is, whether it's for hot flashes or stress or sleep, there's this little bit of the symptoms are forcing us to do something, right? Because it's forcing us to take action or look at our life or do whatever. And if you just give them the hormones, especially with what's happening online, is that like everyone should have it. Everyone's like that's that narrative. So as soon as they get that prescription, they're like, okay, cool. Don't have to worry about anything. I got this. Everyone says I'm fine. And it's like,
Yeah.
I'm curious to see if what else we're going to see that was missing from maybe more people took hormones, but what did they not do?
Yeah, it's funny. Like, I think, when we're feeling our, most, I'll say righteous selves, we're like, we know that there's no silver bullet. We know that, health is complex and requires lots of moving parts. But then on like out of the other side of our mouth that we're like, hormone therapy is going to fix all my
Well,
problems.
but it's like, that's where I'll tell people, I'm like, this is your buy-in. Like, because I'm not even talking to you about getting exercise or food or anything until you're sleeping better. And so this is our buy-in and our step to get to here. But like, that's not it. It's just like, it's just a tool so we can do the next step. But I think it's that communication piece that's really missed. Sometimes it's brought into the conversation, but it's always like, it's not hormone therapy is the buy-in so you can do X, Y, Z. Like, I'll see there's some comments around osteoporosis and like exercise and muscle, especially the protein and muscle mass. That's definitely there as well. But you're not, and this is where I'll see clinicians is missing the point, is telling your patients why we're doing this, right? So once we get this settled, what's the next steps? Where are we moving forward? And that helps them. I think it's also different for me in BC because I'm prescribing. And because I'm the one that they're coming back to for the renewal. And so even if they're like, yeah, my symptoms are good, then I can be like, okay, well, what about this part? And then what about this part? Versus if, say, they were coming to me just for education and then they got their prescription from somewhere else. But I was talking to some clinicians recently with all the platforms and the accessibility of hormones. That's a value that we can bring to patients that they're not getting elsewhere.
Yeah, it's such a good point. And even when I was talking about, getting the prescription and then forgetting to do the rest, I didn't even think about the online options and pharmacies and, on one side of the coin, like accessibility, if accessibility was the greatest issue for you, and this has created this amazing opportunity and gateway, I think that's amazing. But it doesn't replace like the coaching and the human component of health and behavior change. I do see some of those online options starting to integrate people and integrate coaching and integrate more comprehensive healthcare. And so hopefully that becomes the standard and it's not like, mail order HRT. But you're right, it's really missing the point if it just, you fill in a survey and then it arrives on your doorstep. I think that it's not doing for women's healthcare what we deeply desire, which is
And I think
for
that's
the
the
woman's
biggest part. Like,
story.
it's great that
Yeah.
it gives access. It's like you said, if there was a barrier to care for prescriptions, this is awesome. It's great that there's more information out there. There's more advocacy. Women are asking for more. They're realizing they don't have to suffer. This is all really good. It's just that the mask that the hormone therapy seems to be standing behind for some. And it's again, like you said, the pendulum swinging the other way. We just advocated so strongly that we forgot, like women forget there's all this other stuff. And we're busy, right? So I would love if that was it. I really would. And I didn't have to ask you to do other things. Like, I would love to, but
I would love that. I know. Like, give
usually
me
that's
some
the case.
coffee, and that could be it. Yeah.
Dream. Like, I wish.
And I'd love to talk about some of the options that are out there for people, because I think the other thing, when we put something on the pedestal, right? Like, let's say we've put HRT on a pedestal, which I think we have, then it starts to cloud other options and other choices that people have had access to all along, and start to confuse what is the best option. And the thing that I think of right away is something like birth control, right? We have lots of people on birth control in their 40s because they don't want to have a baby. And now they're being marketed to that hormone therapy in your 40s is the right way to go. Can we just talk about those two options and why someone might choose one over the other, and how to stop thinking about them as one being maybe superior in all cases?
Absolutely. And I think it's almost because there's two parts happening, right? Where there's contraception and the need, like the desire to not get pregnant is its own health concern. And then there's the menopausal symptom management as another concern. And we have to find a way to treat both at the same time. And I think it's where if we try to mask and put everything into one lane, that doesn't work. And we have to separate out these issues as two separate health concerns and what fixes both. And hormone therapy does not offer contraception. And if a woman does want to do hormone therapy and not the pill, we can look at an IUD or options like that. For the most part, honestly, I feel like a lot of my women, their partners have had a vasectomy, and that's not a huge concern. And the birth control pill honestly comes into conversation where they are choosing the birth control pill over hormone therapy because they need to worry about other things. And so there's the roller coaster of hormones that's happening in perimenopause. And if we're using birth control, we're telling the ovaries to be quiet. We're going to put them in the corner, tie them in a bow. We're going to deal with you later. And we're going to deal with all of the other stuff over here. So if we're on the birth control pill, it just lets us symptoms are over here. This is where now we can work on stress management, your nutrition, all the other big things that your perimenopause symptoms are making inaccessible. And then the hormones I'm trying to add hormones on top of the roller coaster, right? Just so to balance you out. Sometimes that's fine, but there is going to be a little bit more of a bumpy road because I'm victim to your own ovaries just like you are. I don't know what they're going to do. And it's really up to the women to pick what value fits them there. And so for some of the women who are peak of their careers, or they just they're I can't, I can't handle a roller coaster. I just need something consistent. I need to know when I'm bleeding. Great. The birth control pill is a fair option, and it can be safe. But it's that education around why we're using it, and then how that transition into hormone therapy might look later. Because the one thing which I'm sure you hear as well is you need to start hormones as soon as possible. That doesn't, no. We don't, it's not when you're 30, not when you're 35. This is we're talking about at least not 12 years postmenopausal. We're not talking super early. And there's two parts to that. As one, I feel like women are just searching for information. They want to feel better. And right now hormone therapy is taking the big voice there. And so they don't realize that birth control might be a fair option. And then the other part is that the social media is also making them feel bad for choosing birth control. Mm-hmm. And mm-hmm. I'm not anti-birth control pill. I'm just anti-pill without education. And so I feel like the woman needs to understand what she's choosing, why she's choosing it. And when, in that, the example I gave before, they're taking the pill so they can focus on something else. And that is the easiest choice for them. And it fits their values. They deserve to have the option between birth control or hormone replacement or whatever, and then they can choose. But we just really need to stop making women feel bad for either choosing something or not choosing something, because we have no idea why they made the choice they did.
I love that. And I think too, so the big piece there is that, the birth control pill stops you from ovulating, right? That's how that works. And it provides a consistent dose of hormone every day. Now, arguably, the dose of estrogen is, we call it supraphysiologic, meaning it's a little bit more than maybe you would have made on a given day, but it's at least consistent, and it suppresses ovulation so that you're not experiencing the rise and fall of hormones every couple of days, which is what happens in an ovulatory cycle. Hormone therapy does not suppress ovulation. And so if you are in your 40s, you will continue to ovulate. And although the HRT may smooth out parts of your experience and may eliminate some of the menopausal symptoms associated with your perimenopause experience, like hot flashes, etc., it doesn't completely eliminate your own internal hormone production, which can leave you with the same ovulatory symptoms as you had when you were in your 30s or when you weren't on hormone therapy. So if your PMS is really significant, if there are parts of your cycle, if your bleeding is really significant, there are maybe parts that HRT does not mop up for you, because that's not what it does. And so I think that that's a really important piece. If ovulation is crippling you every month for whatever reason, you deserve to have choices brought to the table that might eliminate that for you in a way that is safe and helpful and effective, and also maybe temporary, because eventually your period will stop or your ovulation will become less frequent. And then you can 100% transition to using something else or HRT and not feel bad about it, like you said.
Yeah. And I think that's like the choices. That's the biggest part that's missing on the space in physicians' offices, et cetera, is like online, all we hear is just hormone therapy. And then sometimes they'll go to their GP and all they get is the birth control. And like there's no choice given or conversation about why something might not be a choice for them, right? And there was a line somewhere where, and I just really liked it, that hormone therapy may not be the best decision for everyone, but everyone deserves the discussion about it. And so whether or not, even the birth control pill, that might not be a good choice for you, but you should know what the options are and why or why not you would choose something, and including even going natural, like just supplement based, etc. Because then it's up to you what works and what fits your values, but you get to decide, and then you would know also when we would look to transition to something else. Because it's the choice part that I feel like women are really missing, and they don't know how to make the choices right now because, one, they don't know the options, and then there seems to be this really strong bias to one decision.
Yeah, it's pretty rare that we come across information guide that just flat out explains all of the options without any emotion wrapped up in any of them. It's very rare. And it's funny because it's like, I guess that doesn't sell, right? If we were like, and here are the positives and negatives of the pill, and here are the positives and negatives of HRT. Like, it really is not a flashy headline. And so it goes against all advertising principles to say there's pros and cons and it's your choice, right? Like, that really goes against everything we ever teach about marketing. And yet this is like the very thing that probably is going to be, what changes women's healthcare, is to create the space, the resources, the tools, and for the clinicians to be able to remove the emotion around what they pick. And I think I love having the birth control chat with you because even in our industry, we can see a lot of negatives about talking like about the birth control pill, and that really just makes me crazy.
Because like it's such a underutilized and undervalued tool, and this is like a whole side step of it, but contraception is what helped women move forward. Like, if you look at bringing like a third world country up until like a more developed space, it's women having choice around when they have babies. And so contraception is so much more than just symptom management. It's what helps us choose when we want to get pregnant or when not. And we can't, like, why do we want to make women feel guilty for not wanting to get pregnant at certain points and choosing to have one pill instead of whatever? Or like, it's just, there's so much more than just that. And I think when we let our industry biases or what we're supposed to think about it get in the way, we miss these opportunities to really help women. Because they're feeling really guilty about going on the pill, but they really don't want to get pregnant. And then so they won't talk to anyone about it, or they don't know their own, like their contraception options that they have. And it's a huge part of a woman's health is the choice to not get pregnant.
Yeah, I think people forget, and even clinicians forget, that a woman's like single greatest health risk is an unplanned pregnancy, right? From the economic standpoint, from the workforce aspect, especially as we're talking in perimenopause, they're just percentage-wise higher risk pregnancies in your 40s. And so to deny that option being on the table means that we've actually exposed our patient to the single greatest health risk in women's health. And, and for what reason, right? What's often being cited is like the toxicity of the pill, or that it's depleting B6. And I'm like, she won't care if she gets pregnant at 44 that her B6 was adequate. Trust me. It's really taken the whole thing. She has a lot of other things to think about.
The other part, and these are things we'll never know, but what are we also making worse when we don't give them that treatment? Like, if someone has very significant PMS, PMDD in a way almost, and that the 2 weeks of the month they're like mood is making it so they're non-functional, what are you taking away from them by not treating them? And like, sure, yes, there's other options and we can look at like natural, etc. But sometimes time, right? Thing with like medicine is it usually works much faster than the naturopathic stuff. Like, I hate to say it, I wish it was faster, but it's usually faster. And so 6 months matters when a woman is not showing up to work, when she can't take care of her family. Like 6 months of delaying improvement does matter. And then, but you can, if we can look sometimes at the birth control like a tool, like I will in the perimenopause woman, where it's just like, okay, let's just deal with this and like tell it, like, let's just deal with those symptoms for a second and put it over there. And then we can manage everything else and pick back up your life a bit. And then we can maybe come off and actually manage your hormones.
Yeah, like if 2 weeks out of the month you are completely debilitated, like what would life be like for you if you just got to put that backpack down for a little bit, right? And I think that that's such an important part of the conversation is that, every step we take in medicine with patients really should be about creating leverage in other parts of their life. Are you taking your Advil so you can exercise so one day you maybe don't need the Advil? I think that that's how we need to think about each of those steps. But when we moralize the conversation, we create this lack of momentum and lack of ability for those people to gain any traction. Because now you're saying, hey, you got to eat clean and you also have to feel like shit 2 weeks a month because we're not going to prescribe the pill. Like it's really not fair to expect that kind of improvement when we're also going to withhold something that might actually help them.
And there's so many options with the pill, like especially if we're talking pill, or yes, more so the pill. There's like the progestin, then there's the estrogen component. And we can, if you had a bad response to one birth control, there's so many other formulations that we can try if that's a direction you do want to go. And I think the other part of where it is just giving more information is also telling them about even like the B6 stuff. Like, here's what you're going to hear about why you might not want to go on it. Here's what we do know about being on the pill. And here's how, like, here are some side effects. Here's how you might feel different. Here's how you might respond differently. Like, because if you are on the birth control pill, you're not going to have that really great follicular week either, where you're just going to feel like you can crush life. But that might be okay with you if you don't feel like crap for the last 2 weeks. But it's just having that full conversation so they know that when someone does challenge them, they're like, yeah, I made the decision to do this, not, oh, I didn't know that.
Yeah, I think if more decisions in healthcare felt more empowered, right? If women felt powerful making the decision, they'd be able to like block all of those naysay moments. But it's like we usually feel like we didn't have another option, or the choices were limited, or we were kind of talked into it. And then when those negative comments come in, we're like, we can't really defend ourselves against them because we didn't really truly understand it or believe it in the first place. Tell us, Brittany, like so if someone is on the pill, or if they're now like, oh, maybe that is the best option for me, how do we transition that person when they do start to get to menopause? And I think clinicians struggle with this too, is how to make that transition. In your opinion, what are the things that need to be considered?
So the contraception is the big one, right? We have to kind of make sure, like to the best of our ability that we can, that they're not going to ovulate and get pregnant. So I will, unless if the partner is out of vasectomy, obviously this is a different story, but I'll tell them to use a barrier method for the first few months because we don't know. I have a 56-year-old who is still ovulating almost monthly. Like, we don't know. Because the recommendation is you go until 52, you come off the pill, and you go on to hormones. Like, that's what it is. Because in general, they, I don't know who they are, but we're going to call them they, the higher up people who tell us
royal they.
That the risk of getting pregnant is so low that you kind of don't really need to worry about it because you're assuming that they're going to be in postmenopause. But it is still a thing, and I just would rather not get those patients pregnant. You can kind of just do a pretty seamless transition of just going off the pill and going on to hormones. The hard part is that you don't know what symptoms are need to be managed. For the most part, what I will find is a lot of the pills will have a 7-day placebo like the sugar pill that you're taking. We're moving more to a 4 day. So some of the newer ones are only 4 days. But you will see that either like menopause symptoms are coming in that 4-7 day window of sugar pills because you're now hormone free. So your body gets a hot minute to experience what it's like without hormones. Or we're getting symptoms that are coming on top of the pill, where the pill is no longer treating those. And that's generally signs of when it's time to switch. And specifically, if someone already had, like their partner has a vasectomy and we were using the pill for symptom management, that's usually the like, hey, you're probably on a baseline lower hormone level. It's time for us to look at another option for you because this is not covering it anymore. On the contraception standpoint, I feel like that does make it a bit trickier because you're supposed to be off for a couple months and then check your FSH to make sure that you are technically postmenopausal, but as we know, that can also be a lie and your ovaries could randomly ovulate. So you are sort of taking that like assumption and just hope in that case, but it's thankfully actually relatively easy. It's just more you don't necessarily know what your patient's symptoms are when they're on the pill directly to the hormones.
Yeah, and I would say I've had that experience with people as well that were on, say, an IUD, right? And so they were never getting any kind of feedback about whether or not they were having a period or ovulating or whatnot, and then transitioning those people onto HRT was just as, felt a little difficult for them because we didn't quite know what was what.
I love an IUD.
They were my dream patients too. I'm like, oh, you have an IUD? Come on in. Welcome. This is the best. Yeah. And just for context, we have so much more flexibility what we can do when people have that uterine protection from an IUD. But when you don't, you need progesterone on top of your estrogen. So the dream patients,
like abnormal, like heavier bleeding and irregular, like it can just make the periods worse. So when the IUD is there to manage that side effect risk is way less. So we have much more play with the estrogen to improve your symptoms.
Yeah, but I think that gives good context. And I would say that, like, again, that transition from one to the other, sometimes we've kind of made up things that need to happen. I've seen lots of people's like protocols for detoxifying from the pill first and then going on HRT, or like you said, you're right. The gold standard would be that we wait and we test your hormone levels to confirm that you are menopausal and then start you on HRT, but nobody wants to feel like garbage for 4 months while we wait for that.
I don't think that patient's coming back to me in 3 months and they've now somewhere else.
That's right. I really want to see this one number, so you are not going to sleep for 3 months. Yeah, it's just really not that practical. I think it was always a relief for patients to realize that you can pretty seamlessly transition from one to the other. It also gives you more confidence in choosing the birth control option because you know that when it does become medically appropriate for you to change teams, you can. You don't need to try out.
Yeah, you're just not usually doing the same ease-in that if someone started hormones in peri, they're probably maybe first starting with progesterone and then estrogen comes on top and then they slowly increase their doses they need. If you were on the pill and you're doing a transition directly over, you're going to start on both and probably at a higher dose than someone who maybe started in peri. It's really the only thing.
That's it. Yeah, it's easy. So Brittany, for our listeners, and I want to kind of wrap up 2 things here. One is I would love for you to share how our listeners can get in touch with you and how practitioners can get in touch with you too, especially in your local area, for you to support them. But also when you think about, wrapping up this conversation about women's health is more than hormones. Women have lots of hormone choices, especially in perimenopause. What are your lasting thoughts for our listeners? Like, how do they get started actually getting what they need out of their healthcare to have these like fulsome conversations with their practitioner?
Yeah. Okay. So first, so you can find me on Instagram, drbrittschamerhorn.nd. And then honestly, everything is on there. So you can also email me or go to my website. Both of those are fair options. I would just reach out. Clinicians, I am mentoring some clinicians, so I'm more than happy to take someone in, especially if you're in BC. And I'm always looking for associates, so that's great too. The biggest take home, I would say, is that for women and honestly clinicians too, but to expect more. And what I mean by that is we as women are really good at saying it's better, it's not 100% gone, but it's okay. And we're really good at accepting not feeling good, not feeling confident, not like we're okay, we're at 80%. I was at 30, so now I'm at 80. But we can expect more, and we can ask of more from like the healthcare system, from our healthcare providers, and even from like the world to give us the information. And it's just asking to get those next steps. So if you're not feeling confident in that decision, ask more questions, because there's generally going to be more offerings. Or if they feel like, if someone says, no, this isn't an option, ask why. But it's okay for us as women to expect more. And I will say this to my patients all the time, because they'll be like, okay, well, how are the hot flashes? And they're way better. I'm like, hey, are you getting in? And they're like, okay, well, 4 to 5 a day still. I'm like, what? No. Like, you get to expect more from me, too.
How is that way better?
But it's like you get to expect more from me as well, where you can ask for more for yourself. And we're just not really good at that as women, and feeling like we can deserve more, or that it's even possible. And I think that's the big part, is that really this whole person care is possible. And if you should feel like your treatment plan is covering all aspects of your health, not just your current symptoms, but also your prevention aspect. And sometimes it does take us actually taking ownership, though, to know I am paying attention and I'm asking for my future health to be cared for, because we're also not really good at that. We're really good at just making sure we feel good enough to do the things we have to do today. We have to ask, am I keeping in mind, am I going to feel good for years moving forward?
I love that. And I think too, we kind of said this earlier, that whatever choice you choose to manage your hormones really should feel like it is just unlocking greater potential in your health. It's, to your point there, it's not about how can we just like smooth things over so that we can still do our 60-hour work week and not really exercise and not address all of these toxic relationships that we have. That's really not the point. The point is that whatever you're choosing is to unlock another level so that you can actually start to work on your health in a deeper, more meaningful way. So whatever symptom it is that's getting in the way of you being able to do that right now, that's what your hormone therapy, whether it's birth control, IUD, or the pill, or HRT, sorry, I said the pill twice. That's what that needs to do. Yeah. It needs to unlock your potential. That's it. Whatever choice you have in that moment, is all we're looking for is one more step forward in unlocking that potential. And then it gives you the ability to do this whole person care. But if we imagine it as something that's just going to cover up our hurts that we have today, we're never going to see it for the tool and the utility that it is. And we will see in 10 years those studies where people have dropped off taking their HRT because they didn't really know why they were doing it in the first place. And that is not what we want.
Great.
I appreciate you spending the time with me. Thank you so much for coming on this show. And we will put all the links to Britt's contact information in the show notes. She's a great Instagrammer, so make sure that you hop over there and spend time over there. Thank you so much for listening. Don't forget to subscribe to the podcast. You're welcome to leave comments on Spotify or leave a review. We always love to hear from you, and we will see you next week.
Thank you.
That's it for today's episode of the Real Integrative Medicine Podcast. I hope you're feeling inspired, informed, and ready to make changes that truly support your health. If you found value in today's discussion, don't forget to hit subscribe, share this episode with someone who needs it, and leave a review. It helps us reach even more listeners just like you. Your health journey is personal and it's powerful. Let's keep building on the knowledge to give you the confidence you need to thrive. It's important to remember that the Real Integrative Medicine Podcast is for educational purposes only. Be sure to talk to your doctor before making any personal health changes. This podcast isn't intended to diagnose you, and no doctor-patient relationship was formed by listening. We'll see you next week.